Well, thank you, Jeremy, and thanks to the folks from ProImmune for having me here. Thanks to the brave souls that have stayed so far and will attend the last session here. The talk I'd like to give today basically is on measuring anti-drug antibodies and the presence of immune complexes, all within the same assay. As far as mastering immunity, to me, it's about mastering the information that we have. And so maybe we have to think about mastering the assays that are at our disposal and what our capabilities are and helping us to make more informed decisions. I'm really going to focus predominantly on preclinical studies, as that's been my area of expertise for the past 25 years. Just to get an idea, I know from the presentation from Bristol Myers Squibb, there's a lot of work going on with monoclonal antibodies. But how many folks here are in some way, shape, or form involved with preclinical immunogenicity? So there's quite a few hands. How many folks are involved with bridging ADA assays? And how many folks do acid dissociation? So there's quite a number of folks that use these assays. What if there was another way to do things is kind of how I approach this talk and is part of the assay that I'm going to present to you today. This might be more of a technical talk, but it's a different way to think about things. And what if you could build an assay that could eventually replace that bridging ADA assay? It is really what I want to put in the back of your mind. So why immune complexes? Well, in order to get an anti-drug antibody, we first have to start with an immune complex. And lately, we've had preclinical studies with some of our biotherapeutics, in particular our monoclonal antibodies, where we've seen adverse events, but we haven't seen the presence of ADA. Usually, sometimes that's due to the presence of circulating drug in the sample that's going to interfere. If we're using a typical bridging ADA assay, we're using our drug to capture and detect the antibody. If circulating drug is present, that's going to present us a problem. We can overcome that problem with the use of an acid dissociation assay, but again, there's still a chance we could get false negatives. We're breaking apart the complex. There's still work that has to be done, and determining the right acid, determining the right molar concentration, it can become very resource intensive. And so what we asked ourselves is, can we develop a ligand binding assay that can determine the presence of free ADA as well as the presence of complexed ADA? And it turns out I didn't have to go that far back. In 2010, an ELISA was developed using this very format that I'm going to show you in a couple slides. And essentially what they did was they came up with a drug-tolerant way to detect immune complexes in monkey samples. And as early as 2013, it was a modified version for the MSD, and in 2016, another paper dealt with the concept of plug and play, so that if you have a human therapeutic, a monoclonal antibody, you develop this assay for one monoclonal, it should be good for any future monoclonal that you develop in the future. So what is the assay? So basically we'll start from, whoops, that didn't work. Let me go back. Pointer, laser? Top one. Oh, that makes sense. So let's start at the bottom. What we're going to have here is a typical streptavidin plate and an MSD assay. We've got an anti-human capture reagent. Now, there's two features about this capture reagent. One, it's commercially available, and it's already biotinylated, so we don't have to make anything up. The other interesting concept about this reagent is that it doesn't cross-react with monkey IgG, and that'll become important when we get to our detection reagent. In the middle, we've got our immune complex that's been formed. Now, this can be a dimer, a trimer. You could even have hexamer structures, immune complexes that form within the animal. But basically, we want to focus on one ADA attached to one drug. The drug's going to get captured by our capture reagent, and we're going to use an anti-monkey IgG. Two important features. Again, this is commercially available. However, it's not ruthinylated or tagged. You would have to do that on your own. But it doesn't cross-react with human IgG. So basically, your capture reagent won't detect any of the monkey ADA unless it's already bound to the drug. and your detection reagent won't pick up your capture reagent or your drug. This complex needs to form in order for you to get a positive signal in this assay. So what happens, how do we measure free ADA in this assay? As I mentioned, we're going to be capturing the drug, but what if there's no drug, and what if there's just monkey ADA? We know our detection reagent is going to bind to that, but we're missing something. So what we figured out, and what the literature says, is that if you spike in free drug at different concentrations, you're going to create that complex, which can then be detected. So now we've got our complex formed. The drug can now be picked up by our capture reagent, and now we can detect monkey ADA that's already there. But there's one issue. For a suitable PC, a positive control, we would need to have monkey ADA readily available. That's one of the reagents that's not commercially available. We just don't have a monkey anti-human IgG that we can purchase. So this would need to be generated. And in order to do that, it would require immunizing monkeys and then pooling together the serum, and then we would have to have our own PC. So this is taken from the 2010 paper, and basically what they do here is by spiking in various amounts of drug to a sample that has free ADA, you're going to see an increase in signal. And eventually you add enough drug that you get a peak. And basically you're going to get a nice bell-shaped curve based on the amount of drug that's in there. This increase in signal basically represents the presence of free ADA. And when you have enough immune complex that's been formed, you're going to reach this peak or a plateau, and then excess drug is going to cause it to compete with your capture reagent, and you're going to see an eventual decrease in signal. Does that make sense so far? So we tried to reproduce these results. Basically, we're going to follow the same format. We generated our own positive control, monkeys that were immunized with a monoclonal antibody. We spike in drug. This represents our 1 to 100 dilution. We've got a little bit of immune complex here, and as we spike in drug, we get an increase in signal, and eventually it levels off, but it didn't quite decrease. We got 3/4 of our bell-shaped curve, but we didn't quite get there, primarily because we had so much ADA present in the sample. So what we did is we did a further 10-fold dilution. Now you see we start with a lower immune complex signal. We reach that peak sooner, and now we can see it's starting to decrease, and we're starting to get that bell-shaped curve. Finally, at 1 to 10,000 of our positive control, we get a nice bell-shaped curve. And even at 1 to 100,000, you can see what looks like a little pitcher's mound, kind of a small hill, small bell-shaped curve. But basically what this tells us is that if we alter our MRD, we could control the sample that we test. And you'll see that the peak gradually shifts towards the left as you go down, as you make the sample more dilute that has the ADA in it. So that's going to bring us to our first case study. We looked at rhesus monkeys dosed weekly for 4 weeks with a MABDAB, a bispecific MABDAB. We had 2 animals that showed mild signs with mild vomiting after dosing, and 2 animals that showed severe reactions. Those symptoms are listed there. One of those 2 animals that showed severe reactions died during dosing after the 4th dose. You can see what the necropsy showed. And in our assay, we're going to look at a MRD, minimum required dilution, of 1 to 100, and we're going to look at drug spikes of 110 and 100 micrograms per mil of the MABDAB. So starting with, this is the data interpreted by individual animal. So here's animal A. What we're looking at here, if you look at the red color, that's going to represent week 0. We can see that there's not much signal there. Green represents week 1, blue 2, and purple week 3. What we're looking for are patterns or trends in the data interpretation. And we also have pre-dose, and then we have 1 hour post-dose at each time point. So if we look at animal A, we could see at week 0, before they've even been dosed, there's not much activity going on. It's pretty consistent, pretty parallel. At week 1, we see again, there's not much activity, and we wouldn't expect there to be much activity after 7 days of dosing, or 7 days prior to that, after that first dose. This is where things start to get interesting. Pre-dose week 2, we see that there's an immune complex signal, and as we spike in more drug, we see a decrease. So we're on the right-hand portion of that bell-shaped curve, implying we've got a specific immune complex signal, and as we spike in more drug, it will go down. After dosing, we see that the signal is lower, but we see the same trend. It follows the same pattern in terms of the decreasing amount. Finally, if we go to week 3, we don't see any increases in this animal. There's no free ADA in this animal. And if we look at the immune complex response 1 hour after dosing, we see the same kind of trend going down. We look at animal B, again, much tightly packed together. These are negative responses of what they look like. There's no increase in signal. Everything looks like it's going on a downward trend, and when you compare the two, it looks like they practically overlap. Animal C and T are absolutely different. Looking at week 0, clearly there's nothing going on here, but week 1, 7 days after that first dose, there's something going on. There's an immune complex response that's the highest among all the animals. And you can see that there looks like there may even be an increase pre-dose, suggesting that as early as day 8, there may be evidence of ADA or something that's binding perhaps IgM, and then eventually that signal is decreasing. And here's where at week 2, we see a substantial rise in signal. This is evidence of ADA. Unspiked, there's nothing going on, but as soon as we introduce 1 microgram per mil of drug, we're going to get an increase in signal that represents free ADA, and then you can see it goes even further up at 10 micrograms and then starts to drop off. At week 3, pre-dose, we see less of a response, but a huge amount of free ADA that plateaus and then starts to drop off. If you look at post-dose, this is week 2, you can see that week 2 and week 3 show the same patterns. There's a high level amount of immune complex, meaning because we know that there's a lot of free ADA, as soon as you hit them with the next dose, it creates all this immune complex, and then we could see that it follows a similar pattern that we saw in the previous animals. And for animal D, again, week 0, week 1, not much going on. At week 2, we see evidence of free ADA, level still increasing and then dropping. And then 1 hour post-dose, all of that free ADA is now bound up by drug, and we start to see the decreases that we've seen in the other animals. So this is data interpretation. We're looking by animal. Here's what the same data set looks like by time point. So in this situation, at week 0, the animals have been broken up into dashed and dotted lines. We still have the same color scheme for our weeks, but we've also broken it up pre-dose and post-dose. So now we get a better understanding of what the data looks like. Week 0, all 4 animals clearly are negative. There's nothing going on. We wouldn't expect there to be anything. But as early as week 1, 7 days after that first dose, we could see the 3 animals here. One animal seems to be ahead of the others, pre-dose and post-dose, and that was animal C. Interestingly enough, animal C was the animal that died. Now, can we make the leap that because of this immune complex response, that was responsible for signs of ICD, immune complex disease? It would look really nice, but we can't draw that conclusion just yet. It's just something that we noted that this animal stands out above the others. At week 2, again, here's animal A, here's animal B. Animals A and B were the 2 normal animals. They had the mild reactions. They have the lowest immune complex responses. Animals C and D, they had the highest immune complex responses, and interestingly enough, they were the ones that had the adverse reactions. And you can see pre-dose is where we get that increase in signal. We know that there's free ADA in these 2 animals, whereas animals A and B, no indication of free ADA. And finally, at week 3, we see the same pattern. A and B are down here, C and D are up top. C and D give you the increase, suggesting free ADA. A and B just give you a decrease, suggesting an immune complex specific signal. So again, this is just another way to look at the data. We looked at it by animal, and we see the certain trends and time points. And now we're looking at it by time point. And what you can also see here is you can see how the levels of immune complex post-dose are starting to rise. And you can even see that in animals A and B, how they're just on an upward trend. So there's definitely being ADA produced, but it's not sufficient enough to clear the drug so that we have free ADA. Next, we're going to try to interpret the data with a dot graph, looking at fold change from no spike, the original sample. So we're going to look at no spike to 1 microgram per mil, no spike to 10, and no spike to 100. For animal A, there was nothing going on. We just really see a decrease in signal. There's no indication of free ADA. Animal B, same trend. We just see a downward drop. But animal C, now we start to see pre-dose by the circle dot at week 2 that there's evidence of free ADA, and at week 3 there's evidence of free ADA, again pre-dose. Animal D, we see a similar pattern. Pre-dose, there's evidence of ADA at week 2, and again at week 3. But now if we compare these two levels, we can see that animal C had much higher levels of ADA compared to animal D. So whereas we would normally titer out these responses, now we kind of have an idea of the relative strength of signal between these two animals, just to give us an idea of what's going on. But we could see by week 3, animal D is practically caught up to animal C. So if we were looking at week 3 only, we may not be able to draw any conclusions. Week 2, we might be able to say that there's a difference between these two responses. And even at week 1, we saw that animal C had higher than normal levels compared to the other animals in that group. And again, it's just another way that we can visualize the data. I mean, a lot of us generate ADA data and we have tables with numbers, and maybe the numbers get bolded, maybe they get bracketed. It's pretty much an eyesore. It's not really fun to look at. So how can we visually show the data so that we can start to draw conclusions? How can we start to see patterns and trends that mean something? Now, we looked at fold change from the original response. Here's the fold change from previous concentration. So here we're looking 0 to 1, 1 to 10, 10 to 100. Again, there wasn't much activity in animal A. All the trends go down. This is suggesting if it's an immune complex response, the signal is going to trend downwards. Here we see at 1 microgram per mil, we get our response, and then we can see that the response just starts to drop. And again, for animal D, and again, you could compare these levels and get an idea of the relative strength of the signal, and then you can see how the pattern tends to drop, suggesting that it's specific. It's on the back end of that bell-shaped curve. This is just the two slides that I've just shown side by side. Again, it's another way to visually look at the data. It's not telling us anything new that we didn't see on the previous two slides, but it just helps us get an idea of the kind of data that we're generating, and perhaps why in this assay it's important to have 3 drug concentrations instead of maybe 1 or even 2. We want to establish patterns. We want to establish trends that can help us make informed decisions. And one way we can do that is by how do we determine what's a significant response? Now, for this particular assay, there's only 4 animals. It's a very small sample size. And so we came up with the dreaded arbitrary analysis, and we decided to use a 2-fold change. Any signal with a 2-fold increase above would be a significant increase suggesting free ADA, and anything below a 2.5-fold drop would be a decrease suggesting that it's immune complex specific. And basically we're looking at this data set right here. This would all be normal data. These would be free ADA, and these would be immune complex specific responses. And so now we're going to look at one final graph of the data based on the patterns and trends that we saw on the 2.5-fold change. If it's red, it basically means it's consistent. This is negative. These are negative responses. And certainly at week 0, this is what we would have expected. At week 1, it's animals A and B that give you the negative responses. But by the purple is a consistent response that then significantly decreases, suggesting that this is an immune complex response. And you can see for all of the purple, you can see how much of a drop we're getting here. This means that this is a real response and that we're getting a significant decrease. And you can see this all over. You can see this is the pre-dose for A and B. We're getting that significant drop. And of course, The green represents an increase, and the blue represents an increase, consistent or plateau, and then decreases. And so right away we can pick out which animals represent samples with free ADA. And of course, with the post-dose, we don't see any evidence of free ADA, which means that the assay is working as intended. But right now, this tells us right away we want to focus on these animals that are establishing signs of free ADA and that are measurable. All right, this looks like a busy graph, but we'll focus on them one at a time. Let's start with the red. This represents the PK. This is the amount of drug that's in the sample. This was either monkey A or B. It was the one with a mild reaction. After dosing, 1 hour after dosing, drug levels spike up. 1 week later, they've come down, they go up, they seesaw back and forth. This is basically a normal response that we would expect. If we look at our bridging ADA, we see maybe a little spike here, but then after you dose, everything goes back to baseline. This is a pretty normal response, suggesting that there's minimal ADA here. If we look at the immune complex response, the CIC represents the unspiked blue line, and you can see that it's pretty much covered by the green line. And what this green line represents is our CIC plus one of our drug spike concentrations. And it basically gives us our peak response, our highest gap. But we don't see any gaps here. This basically means there's no free ADA present. And what we see is that after day 8, by day 15, we start to see that there is some kind of immune complex present here. And it seems to be consistent across the next week. So there is evidence that ADA is being generated, but it doesn't seem to be having an impact on the clearance of drug. So this is data that we're generating that helps us interpret what could be going on, and that if there were adverse events in this animal, we do have evidence that immune complex is being formed and could be leading to the cause of that. Now, here's a monkey with severe reaction. This looks pretty busy. But if we follow the red line, this is our PK, and we see that by day 8, there's still some drug on board. After you dose, there's a lot of drug. 1 week later, the drug's been cleared. And then you see this consistent bounce up and down. Immediately after dosing, high levels of drug. 1 week later, it's gone. Right after dosing, it's back up. This animal had severe reactions after dose 3 and dose 4. If we look at the black ADA lines, this pretty much follows what we would have expected. At day 8, maybe there's a little bit of ADA actually present 1 week after that first dose. But right after they dosed, this is after the second dose, the ADA assay is compromised and we don't see any signal. It's back to background. And then day 15 pre-dose, a lot of ADA, and we see the same pattern. After dosing, the ADA levels go back down. 1 week later, they're back up. With the immune complex assay, we don't see anything early, but by day 15, we know that there's free ADA, and this is the immune complex signal, and this is the immune complex plus spike, the green line. This gap represents free ADA. So we're actually picking up the presence of free ADA, matching what the ADA assay tells us. But on day 15, 1 hour after dosing, we see that there's no gap. It's been closed. But the immune complex levels are still maintaining a fairly high level. And then at day 22, pre and post dose, we see the same thing, this big gap of free ADA, and then immediately after dosing, all of that free ADA is bound up, and we're left with this immune complex signal. And to wrap up, to summarize case study 1, I think it's important to note that the assay that we're using is basically confirming what the ADA assay has been telling us, but now we've got more information to share. We've got more information on immune complexes that we wouldn't have had before. But wouldn't it be nice to know what's happening during the time course of dosing? If we had an aggressive time point selection, wouldn't it be nice to know what's happening, say, every 15 minutes? And that's what we're going to do on case study 2. Based on those results, we knew we had to look more in depth to what was going on. We just couldn't have 1 week after dosing and then 1 hour. It just didn't seem like enough time points to really get an idea of what was going on in the sample. So actually, case study 2 is how we generated our positive control. We immunized 4 monkeys with a highly immunogenic compound once a week for 4 weeks. We collected 15-minute time points after dosing, after the 4th dose. And then 1 week and 2 weeks after dosing, we collected some production bleeds, and we pooled those together, and that's how we generated our PC. So our plan was to test all of these time points in our CIC assay. Samples tested at 1 to 100, and we used the same 3 drug spikes, 110 and 100 micrograms per mil. So here's a sample representative of what one animal looks like. In this particular animal, day 1 and day 8, there's nothing going on. That's what we would have expected. But day 15, we see evidence of here are the 4 drug spikes. The blue is the no spike, gray is 1 microgram per mil, yellow is 10, CIC is 100. We start to see a concentration-dependent response representing free ADA in the sample. Day 22, before the 4th dose, we see an even larger gap, and again, a concentration-dependent dose response suggesting free ADA, indicating that the assay is working very much as intended. What happens 15 minutes after that 4th dose? We see an inverse relationship. Our immune complex signal, all of this free ADA is now being swamped with drug. We get a large immune complex. It looks like we've reached the plateau of our signal, and that as we add more drug, now we're on the right side of that bell-shaped curve, and we're actually seeing inhibition. So we're actually going down the right side of that bell-shaped curve, seeing a decrease in signal. 30 minutes later, it's kind of a jumbled mess. And as we get off of that plateau, all of the numbers, all of the spikes appear to be knotted together, become really close together. And we see that at 2 hours, 3 hours, and then maybe at 4 hours, we start to see a little separation and maybe an indication of free ADA being present. 1440 is 1 day after the 4th dose. Now we start to see a concentration-dependent response suggesting free ADA. 2 days after, again, free ADA. 1 week after, large amount of free ADA. And 2 weeks after, again, a lot of free ADA. But as we can see, as immune complexes drop, you can clearly see the rise in the measurement of free ADA. And on the next slide, here's where we take into account all of our assays. Again, the red line represents the drug. You can see where the drug has bottomed out pre-dose on day 15, before the 3rd dose and before the 4th dose. The drug's already been cleared. As soon as you dose, it's all the way up here. You can see the trend of it's being cleared, and then you can see eventually by 1 day after the 4th dose, all the drug has been cleared. And if you look at our bridging ADA assay, yes, we're picking up ADA before the 4th dose, but as soon as you introduce drug, it flatlines. And it's only until the drug and the immune complex are being cleared that our ADA assay can now pick up ADA, and we start to see a significant rise. And basically, the immune complex signal and the CIC spike, if we look at the previous, this gap here, this would be our CSC plus spike signal, and this would be our CIC signal. So basically, this difference here represents the amount of free ADA that's there, and then you can see how close together they are. And again, as drug is cleared, immune complex is being cleared, and finally, when they're at low enough levels, now our bridging ADA assay can pick them up. So what are the advantages of this assay? Well, one, having commercially available reagents is certainly always handy to have. Every monoclonal therapeutic that we come across, we have to biotinylate and tag to derive our own ADA bridging assay. Number two, by using an anti-human IgG capture, this assay format can be used as a plug-and-play approach for any humanized monoclonal that comes down the pipeline. I know with Bristol Myers Squibb, there's a lot of those coming down the pipeline. Same thing at GSK. There's been a lot of resources given to developing human monoclonals. So we know that this assay format for preclinical, at the very least, will be very important to utilize for all of those compounds coming down the pipeline. If we wanted to, we could transition to mouse or rat with a commercially available anti-rat or anti-mouse detection reagent. Then all you have to do is tag it. But what's neat about rat or mouse is that there are mouse anti-human and rat anti-human IgGs available. Those would be suitable as a positive control. There just doesn't happen to be a monkey anti-human IgG reagent commercially available. So the one, as we'll get in the next slide, one of the drawbacks is you're going to have to generate a positive control. If we utilize the drug spikes, we can distinguish between immune complex signal and free ADA. Your basic bridging free ADA assay, even if you're using acid dissociation, isn't going to tell you anything whether that ADA is complex or not. The binding capacity of the well determines drug tolerance, not the assay format. You're not limited by the biotin and tag drug competing with circulating free drug. You're basically at the mercy of the well and how much biotinylated capture reagent it can hold. And that's why you dose different drug amounts, is that you can now establish a pattern, whereas if you see a drop, you know that it's immune complex specific, and if you see an increase, you know that there's free ADA there. 6 is theoretical. I haven't gotten to this yet, I haven't proven it, but I'm theorizing that multimeric targets should no longer yield false positives the way they would in a bridging ADA assay. If you have a compound that's a dimer, the target could bind the two together and you could get a positive signal that way. But based on the method that I've shown here today, I don't think it'll be likely that the compound binding to its target will still pull down the compound, but if there's any ADA there, whether or not it's interfering with the ability of the compound to bind to the target, we should still be able to pick up that signal. You could have some steric hindrance based on how large those complexes are that are being formed, but it's certainly something that's on our checklist of things to do as part of our upcoming strategy to determining how feasible this assay really is. The assay doesn't require separate assays for confirmation or titration. The drug spikes actually tell you information on whether or not you can actually use the drug spikes to confirm that it's free ADA or whether it's an immune complex specific signal. And if you think about it, if you screen and you run your confirmation, you're going to run it unspiked and spiked. And if you run your titration, you're going to utilize your sample 4 times. It's the same thing that we're doing in this assay. We're running it unspiked and spiked with 3 different concentrations of drug. Some of the limits of the assay: plate capacity. You'll definitely hit a drug tolerance wall with enough free drug. One way to compensate would be to increase your MRD. We're currently at 1 to 100. If you could go higher than that if you know there's going to be enough drug on board. You're going to lose sensitivity, but chances are when you've got a signal that high, you're going to pick up ADA regardless. If there's a ton of drug on board, you're probably not going to see signs of ADA, but really we just want to pick up the immune complex signal. We're not too worried about whether or not there's free ADA because the chances are the drug has already been cleared by the time we're able to pick up free ADA. Isotyping would require a separate detection reagent, an anti-monkey IgM reagent. That could certainly give you more information on your sample and the type of results that you're generating. It does require a positive control. You would have to generate your own PC, whether you're going to immunize monkeys or you're going to have to send it through a CRO. That does require some investment. However, if you're building an assay for the human monoclonal, you only have to do this once. And if you do it right, you can generate enough positive control to last you for all your future assays. If you're getting production bleeds, if you're running 3 or 4 animals and you're getting 5 to 10 mils per production bleed, you can easily generate over 100 mils positive control. And lastly, the assay doesn't really tell us about the size of the immune complex. It doesn't tell us how big these complexes are. And what we had to do, if we want to characterize further, we do have size exclusion chromatography and we do have mass spec to help us understand how big these complexes are and what's actually in the complexes. And hopefully if this talk goes well today and I'm asked back, I might be able to elucidate on that further in the next presentation. And that's basically it. These are the folks that I'd like to acknowledge, part of our team. This is our animal policy statement that we have to state, and our statistical group who helped put together all of those wonderful graphs and dot plots that we saw. Thank you.
Thank you very much. Very nice presentation. Thank you so much. So theoretically, if you get antibodies in your monkey to your drug framework, could that prevent it from binding to the plate? So could you get like neutralizing antibodies?
I suppose that would be possible, but for an anti-human IgG capture, I suppose if the sample or the drug was swamped with framework ADA, that there were no binding sites available, sure, that would be possible. I guess we haven't seen evidence of that. And again, 2 studies. That's all we've ran so far. We're at the beginning stages of trying to understand how this assay works and what the capabilities are. And what our strategy moving forward now is on every study that has ADA support, we're adding this assay on so that we can compare it and see how it performs over the next dozen studies. So we can, once we get enough information and once we understand, maybe we reach a point where we say this should replace the bridging ADA assay. It's more informative. We can get more information out of this, specifically in regard to immune complexes. And that seems to be the take back on what we're getting from project teams. It's not enough that they get ADA, now they want to know about immune complexes because they're seeing immune complex disease in animals, but there's no connection. How many times have we seen 2 animals with ADA, high titers, one has immune complex disease, the other doesn't? Sure, we know that there's ADA there, we link it to that, but that's all we have. We don't have anything else. Maybe the immune complex after dosing, maybe it's higher in that one animal. We don't know. And that's really the excitement is we want to see what happens in these future studies so that we have an idea of whether this assay is possible. It just gives us another tool in our toolbox.
Hi, I have 2 questions. The first one is, can we do it for clinical studies? Can we do this assay?
Yeah, so
human, anti-human antibody is going to be tricky.
Yeah, that's a bit of a problem. So the reason we do it preclinically is as you just mentioned, if we capture the drug and you have a human IgG, you'd have to use an anti-human IgG. It's just not going to work. Now, I've tinkered with this, and I've come up with a couple of ideas of possibly how to get around that. I think it's a long shot. It's just not possible clinically. Preclinically, absolutely. Mouse, rat, monkey, as long as you have the reagents, you're good to go.
And my second question is, there's really a nice correlation in the study that you showed and in most study, and with PK levels and the ADA levels. I'm just a question, how informative can be PK data by itself without the ADA data? I know if you have decrease of PK, it could be something else.
Yeah, it's pretty obvious when you see a group of animals and one animal drops off the cliff based on PK, it's pretty obvious that it's ADA, but you have to prove it. I think if you went to the ADA and said, there's a tremendous drop here, oh, it has to be ADA, I don't know how far you'd get. You're perfectly capable to try, but we want to be able to show, we want to be able to prove that that drop is because of the presence of ADA. And one of the problems is we're restricted in our ADA testing by time points. We typically can't look at PK samples because there's circulating drug on board. We kind of are limited to 1 week, 2 weeks after dosing, and by then it could be too late. What if you have an animal that has an adverse reaction and that animal has to be put down? What samples do you have to test that can link the evidence of ADA? What if you could link immune complex? Now you've got something that's directly associated with immune complex disease.
So finally, what do you think about the heterogeneity of immune complexes between animals? Like you may get a low signal because in this animal you have this immune complex that has one drug, and this animal you have an immune complex that contains like 3 drugs, and you're capturing it more, getting better signal.
It's a fantastic question. I can't answer it right now. Again, we've just got 4 animals that we looked at in case study 1. It's not enough. We saw that the one animal C that eventually died, we saw that there were immune complex levels at week 1. 7 days after the first dose that was higher than the other 3 animals. Is that significant? It might be, but I don't have enough to justify that. I can't draw that conclusion just yet, but boy, is it encouraging that that could be a major part of the information that we're generating. So now we just need to take it to future studies and see what kind of data we can keep generating and see if there's patterns or trends that emerge, and then be able to link that together and maybe bring in SEC and LC-MS to determine the sizes of these complexes and then what's actually in the complexes. If we could figure that out, it gives us a lot more information than what we currently have today. And I think anytime we can make informed decisions preclinically, that certainly helps translate to the clinic.
Thank you very much.
Thank you.